Good morning, everybody. I'm Jocelyn Cornwell, and I'm the Chief Executive and founder of the Point of Care Foundation. And I'm also somebody who's come up without her pointer, I think. Can I use this one? I also am very pleased to say that my organisation for the past year has been facilitating the HOPE network, the Heads of Patient Experience Network, for the NHS, which is funded by NHS England, but Point of Care Foundation is the catalyst for it, the coordinator for it, the facilitator for it. We've got over 100 members, people who work, whose primary responsibility or who have a responsibility for patients' experience, either working for provider organisations or for commissioners. We've got over 100 people on the database and have had 3 meetings so far. It's a very vital network, and if you haven't heard about it before, I hope you will take note of it and also tell any colleagues who might be interested in joining, tell them about it, because we'd really like to include them in the network. The purpose of the network is really to help people in those roles develop, to support them and to offer them opportunities to meet with and speak to national and international policy experts and practitioners. So we'd really like to see it grow and continue. I'm really pleased to be here today. I was invited to speak to this conference, and it seems to me that you're an audience which is I hope, really engaged with these issues. What I want to do is start off by standing back for a bit from the immediate moment that we're in 2016 and look back over 20 years and then look ahead to what I think some of the changes need to be to make things better for staff and better for patients in the NHS. So this is the image that comes to my mind when I think about the NHS over the past 20 years. It's wave after wave after wave of change that has really hit people who work in healthcare. Waves kind of each one rising up and towering over the ones that went before. And I think of the staff as very like the people on these boats. I hope you can see the boats that are kind of, struggling through the waves and really being tossed by them. The waves that I have in mind have really brought about a sea change in the way that we think about quality of care over the past 20 years. And people as old as me remember this, but many of you wouldn't, I think. And the change that there's been has been away from a world in which people said, leave it to the professionals. They're the people who can do quality on their own, and we trust them and rely on them, to a world in which, first of all, there was a realization that managers would need to become involved in managing quality of care and supporting clinicians to manage it. And then I think to the current position that we're in, which is a recognition that the quality of care is produced by the whole system, and that if we really want to improve quality, whether it's safety, clinical quality, or patients' experience, it's everybody's business. It's patients' and families' business. It's doctors, nurses, managers, finance people, porters. Everybody is implicated in this work. And the waves that have been were that in my lifetime, in the early 90s, there was a wave which brought national clinical audit into the system and evidence-based medicine. That was followed by, in the late 90s, early thousands, a major effort to introduce into healthcare insights, techniques, tools that were developed in industry and in engineering to change the processes of care. And that's where we see Lean, Six Sigma, total quality management. That was followed by research in the early thousands that showed us that healthcare was capable of causing harm to patients. So in 2004 in this country, there was the publication of a report called Organisation with a Memory, which was the first report that really set the agenda for patient safety and founded the National Patient Safety Agency. So it's only in the last 15 years that we've seen major attention being paid to patient safety. And then more recently, I would say the latest wave, probably starting in kind of 2007 maybe, has been a real focus on patients and their experience of care, patient-centered care, and then most recently, patient involvement and patient leadership. So we're still kind of experiencing these waves that are coming. And each one of them, I think, when you stand back and look beyond the immediate moment, which I think for a great many people feels very like they can only see the wave that's hitting them right now. I think if you stand back, what you'll see over 20 years is that gradually, we're learning to improve the quality of care. And we're learning to have a much more sophisticated understanding of what's involved in quality than we used to have. So, you know, I'm very much a kind of cup half full person. I think that we're going in the right direction. It feels incredibly slow when you're somebody who's very committed to making changes for patients. But actually, I think, given the complexity of the system, I think that we are really heading in the right direction, and I think it's very important for us to understand that and not to be set back by some of the kind of real challenges of the present. So, I'm going to just use examples from acute care this morning, and I'm only going to talk about the experience of care. But I think that my remarks are applicable to other healthcare settings, to primary care, to mental health, to community services, and I think they also apply to the question of how to involve patients, both in their own care and in service redesign and in governance. And when I say patient, it's shorthand. What I mean is patients, their families, their carers, people who are close to them, and if you're in mental health services, I mean service users, but it's too cumbersome to say all of those words all of the time, so I'm just going to talk about patients. Let's look at what's been happening to patients in hospital just over the last 6 years. This is data that the King's Fund published in December. It's a report that deserves to be read, looking at what the national patient surveys tell us about the changes in the experience of inpatients over the last 6 years. And what you can see, the black bars are reporting the data on questions for 2005-2007, the green ones for 2011-13. When you first look at it, one of the things that probably strikes you is that it looks as if there's been very little change at all. In fact, you can see that on some questions, the change, if anything, has gone in the wrong way. It's a minus score between the black and the green. The performance is notably poor in two areas. One is noise at night, which is question number 15, and one is the quality of hospital food, which is question number 21. But I would argue that we should be cautious about assuming from this graph that nothing has really changed. First of all, because the scale is huge, 0 to 100. It's not going to show up small and significant changes on a scale that's presented in this way. Second of all, because we still don't fully understand the relationship between what patients say about their experience and what they say about their expectations. It's quite possible that some of what appears to be lack of movement on experience is actually, in a good way, because people's expectations are rising all the time of what they want from services. And the third reason I think we need to be cautious is because we do know that there's a relationship between case mix and what people say about their experience. That's to say that if you are feeling lousy, you are more likely to say that your experience has been poor in every dimension. This is hospital inpatients, and one of the things that's been happening over the last few years is that the people who are in hospital as inpatients, because lengths of stay are so short, tend to be people who are sicker than they would have been even 10 years ago. So all of that may be affecting the data. So I think, I'm not saying don't pay attention to it, I'm saying be cautious about jumping to broad conclusions on the basis of that. I think it's instructive to look at some of the detail on individual questions. So these are the questions, I hope you can read them, where we've seen the most consistent improvement over this period of 6 years. And the standout one at the top, 149 organisations scored better in 2011-13 than they did in the early period. The standout question is on cleanliness. Hospitals are cleaner today than they were 6, 7, 8, 10 years ago. And what do we know about cleanliness? We know that there was a major policy push which was linked to major incentives and sanctions in the performance management regime, which drove changes in hospital cleanliness because of the rates of MRSA. So what that data tells me is that where the whole system is aligned simply and powerfully around one goal, you can see really quite big shifts over a period of quite a short period of time. The others, which I take to be very encouraging, the other areas where we've seen more trusts improving than deteriorating, are all aspects of relational care, which tell us something about, I think, positive and significant changes in the way that professionals are working with patients and in the way that support staff are working with patients. So let's look at the questions that have most consistently deteriorated. And here, the big hitters, if you like, on this are the largest number of trusts that have deteriorated, 76, have gone down on the question of, from the time you arrived at the hospital, did you feel you had to wait a long time before you got a bed? And the other big questions here are about noise at night and food. And what these have in common, I believe, is that they're all phenomena that no single group of staff have control over. They actually, if you want to improve waits for a bed, if you want to improve food, if you want to tackle the problem of noise at night, it's got to be an approach that involves more than one profession, usually quite a number of professions, and often more than one department at a time. And these are complex, interlinked pieces of work, processes, that are difficult to improve because of their complexity. The standout one that worries me on this slide is pain. Is patients saying that they were in hospital and that their pain wasn't attended to. And that, I think, you can say is a responsibility of staff in clinics and wards, and I think it would be a very good thing if we saw that particular dimension changing. So, the question really that I want to think about this morning is not, has patients' experience improved, but rather, what more can we do to push the wave further along and to help staff in those boats who feel so buffeted by the changes that are upon them? And what I want to argue is that there are three things that need doing. First of all, I think we need to stop thinking that we need to collect more data. and we need to stop thinking that we need to collect more different types of data. Second thing I think we need to stop doing is magical thinking, which I'll say a little bit more about in a moment. And the third is I think we have to try harder to understand the nature of the problem that there is in transforming patients' experience of care, and understand that it's an adaptive, not a technical problem. So, the first quote here is from Carl McRae, one of the leading people at the moment who's setting much of the agenda in patient safety, hugely important in setting up the new investigation authority. And what Carl McRae says is we collect too much and do too little. At the Hope Network last week, when we had a meeting with patient experience managers, one of them said that she felt like saying, we have all the data, so what? Meaning, what are we doing with it? We have a huge amount of data on patients' experience in this country. We have more longitudinal data than any other country. We've had an annual patient survey for nearly 15 years. We've had national staff surveys as well for almost as long. We have surveys of cancer patients, surveys in A&E, surveys in outpatients. We have the GP survey. We also have the important independent websites. We have Patient Opinion and I Want Great Care, who've been there for quite a long time. The places where patients are free to comment on their experience independently of the NHS. There's the NHS Choices website. Most recently, there's the introduction of the Family and Friends test, introducing near real-time feedback. And plus others. Many, many trusts and services have their own bespoke ways of collecting data on patients' experience. The question for me is, what do they do with it? And how do they handle it? I would say that this amounts to excessive measurement. Don Bowick's just published an editorial which says that we only need in healthcare 25% of what we collect if in order to run services and learn about how to improve them. And he's arguing that we should radically reduce the amount of data that's collected where it's burdensome and is not adding value. And I think we need to do much more to make sense of the data that we have already and to use it. So, what about magical thinking? What I mean by magical thinking is the thinking that says, give them the data and things will change. Something mysterious will happen. People will see how they perform as compared with another organisation or a service, and they will change and things will improve. We discovered all through the 90s that national clinical audits did not result in change. We discovered all through the first decade of this century that the national patient surveys were not really resulting in much improvement in the figures. And we need to ask ourselves, what's that about? How is it that people are expected simply to change because they see how they compare with another organisation or another service? What's in that black box that's where something mysterious is happening? So I think that what we need to do is to understand much better than we do now the nature of the problem. So there's now quite a significant body of research into quality improvement. If you look at particularly at the Health Foundation website and the work of Mary Dixon Woods, which I think is both very accessible and incredibly interesting, what that will do is help us all to understand the nature of the problem that we face in trying to transform patients' experience of care. And it's not a technical problem, it's an adaptive problem. So technical problems are problems that are generally very intense when they occur, and they cause lots of distress and disturbance inside organisations. But actually, it's within the know-how of the organisation itself and its staff how to fix it. And so they can be fixed relatively quickly, technical problems. So an example here would be where costs exceed budget, but another example that I was just thinking about this morning on the train on the way here would have been that oil rig that blew in the Gulf of Mexico that BP owned, which was, I think, in 2012. So you get a major event like that, which is a fantastically big, disturbing, distress-causing phenomenon. But actually, there is a solution to it, which is a known solution. It might take a long time, in this case months, to implement, but it's fixable. An adaptive problem is very different. An adaptive problem is one that causes discomfort and distress, anxiety, concern. It makes people unhappy at work. It makes people not get on with each other at work. It makes them dissatisfied. It comes over the long term, and it has to be fixed over the long term. And the task for leaders in the face of an adaptive problem is to keep people in the process able to cope with the discomfort of not being able to find a solution right away, able to think about what the solution will be, and to have some compassion for those. I think that healthcare staff, certainly the ones we work with, are deeply distressed when they see that things aren't right for their patients. But they don't necessarily know how to fix it, and they don't necessarily know who can fix it. And so what we need to do is something quite different, which is not just fix a problem, but actually work with people to resolve it and to create the conditions that make that possible. So what stops staff mysteriously, magically acting on the data when it comes back to them? My organisation offers training and support in improving patients' experience of care. And we've done this for a number of years now, and also through the Hope Network we have a lot of contact with people on the ground. And this work has told us an awful lot about the mechanisms that stop staff simply acting on patients' feedback and letting the magic happen. So sometimes the problem is a technical one. I would say, for example, that not seeing the data, not seeing your own patient's feedback, not receiving it and not having it in a form where it's understandable, that's a technical problem that we ought to know by now how to fix, and many organisations do actually know how to fix it. But the other things on this list, these are all indications, symptoms of an adaptive problem. People not knowing what to do, people not feeling that they're empowered to take action, people not believing that it's their job or that it's not important, it's somebody else's job. Or people being too afraid to engage with the feedback because of what it might tell them about their own service or about themselves. Or indeed, people believing that they already know what their patients want, and so they don't need to listen to them. These are all things that we hear people saying quite commonly. It's not unusual, I think, in many healthcare organisations today to hear these common reactions to the idea of improving patients' experience. I think these last four statements, which I've put in italics, are all important, and I think they're also all interconnected to one another, and I think all of them can be changed, and that the most powerful way to change them is to recognise them and to keep people, to find ways of helping people to engage directly with patients' experience and to show them what they can do about it. I just want to play you a quick little bit of tape here, which will illustrate this. So sometimes people, and in this case it's a doctor, they suddenly see what it's like to be a patient in a way that they didn't before as a result of something in their own personal experience. So this is hopefully...
Her care in my hospital was amazing. She had courtesy, reliable care, efficient care, expeditious care, safe care, the very best that medicine could offer. And most importantly, she was better. I felt quite proud, actually, that my mother could see how great my hospital was and how great the staff were. 2 months later, I visited her at her house, and I just happened to ask her, "So what did you think of my hospital?" And what she said after this, words can't even describe how I felt. Ashamed, guilty, like I'd betrayed her, probably sums up what I felt. And she said that the 2 days I spent in hospital was the worst experience of my life. I spent 2 days petrified, not knowing what's happening to me, what was about to happen, and as far as she was concerned, she wasn't going to make it out of the hospital and see her grandkids again. How can a mother's son, who is a doctor in the very hospital that she was at, not see the world through her eyes? And if I couldn't see the world through her eyes, it was my mother that I dearly love, then what chance did my patients have whom I didn't know?
So that's a surgeon in South Wales, Hiro Tanaka, talking about the experience of his mother, which deeply changed his appreciation of what it was like to be a patient in his own service, in his own hospital. You can't... I'm sorry, I'm very cold. I don't know if anyone else is, but... It'll get better. Good. You can't rely on everybody's mother being in hospital, can you? You can't rely on everybody having a member of a family, their own family, through whose eyes they see how powerfully different patients' experience is from what they assumed. And so one of the things I think that you have to do is to use some of the proven effective methods for helping staff to get into their patients' shoes in order to overcome some of these difficulties that I showed in the previous slide, some of the attitudes. So the next little clip I want to show you is of a consultant paediatrician, Hesham Abdallah, who we worked with, and this is Hesham talking, I hope, about shadowing his own patients, which is something that we teach people how to do, and the impact that patient shadowing made on him, and the ability that came about from doing the patient shadowing to improve the patient's experience of care. Could we play the tape? Thanks. Haven't got any sound.
Changed the approach that we took. And just as an example, all of us, all the guiding council, shadowed patients. But my experience of shadowing patients has stayed with me very powerfully ever since, actually. And this was an experience of shadowing a mother of a child with asthma. And that child had come in with an asthma attack. And she was put onto a cubicle on my ward. And I was shocked by what she saw, actually. She was put into that cubicle. The little boy had a saturation monitor placed on his finger, and the door was closed. And a few minutes later, those saturations started to drop to 92, 91, 90, 88%. And all the while, the alarm was going. And the mother, when I asked her what she was thinking, said, well, you know, the alarm's going, but the nurses look really busy outside, and I don't want to disturb them. And I don't think it's that serious, but I'm not quite sure. And this mother was actually a house visitor, so she had some medical knowledge and some expertise, and yet she was still reluctant to actually pull the alarm cord. And that transformed really the way I thought about safety on my own ward. And from that, we took some very clear actions. We simply increase the volume of the alarms so that they could be audible from the nurse's station, which was just down the corridor. We issued or produced a leaflet to give to parents when they came into our assessment unit, empowering them to pull the alarm cord if the alarm went off, rather than simply hesitating. And those two interventions cost nothing, probably made a huge difference to the safety and security of the ward, and transformed the experience of those mothers or those parents of children with asthma. And that was all really driven by a single episode of me sharing an experience with a patient.
So, I'm assuming, and I haven't seen the delegate list, but I'm assuming that some of you are here from provider trusts and some of you are here from commissioning organisations. So I thought I'd end by just trying to sum up what I think what the implications of saying it's an adaptive, not a technical challenge that we face, what the implications of those are for providers and what the implications are for commissioners, and so some of the actions that you might be able to take or think about taking. So I think in the case of trusts, the starting point has to be to accept the adaptive nature of the problem and to set more realistic timeframes over which things are expected to change. I think there is a technical aspect to this. It's quite clear to me that a lot of trusts don't have the technical capability that they need devoted to making sense of the patient's experience data that they collect. So there's something there about mobilizing the informatics people, the people who can analyze and interpret and present data that is already being collected in a better way, and to package it more suitably both for boards and for clinical teams. But that's the only technical aspect of the problem, really, that I think we can say exists there, because all the rest of it is adaptive. It's stuff that if we want to see it change, it actually means providing leadership which says patient's experience is everybody's problem. It's not the patient experience manager's problem. It's everybody's problem. And I think that quite a lot of organisations would do well to clarify the role of the patient experience manager, who seems to me to be a very underutilised resource at the moment. Often patient experience managers are only confined to doing work on the data, when actually they ought to be able to help and support and lead the work on improvement. I think all organisations really need to pay attention to the research which talks about priority thickets and people having so many priorities that they can't think straight. And we need to radically reduce the number of priorities and just have a few simple ones that organisations can act on, and that they can empower then clinical teams to find the right solutions to achieve those goals in their area. I think staff need much more permission closer to the ground to take action, and they need much more support to make the kinds of small changes that Hesham was talking about, which really profoundly improve both the safety and the quality of the experience for the patients. And the other thing I think that providers should be doing is really thinking about how to connect up internally the comms people and the HR people with the patient experience people. Each of those quite often is working independently of each other. So, for example, patient feedback data is being sent back to clinical teams who aren't getting it because staff on the ground don't necessarily read the one newsletter that comes out every month. So there really needs to be much more linking up of those kind of capabilities internally to support the effort to improve patients' experience. And the list for commissioners is not that different. Again, I think it's about accepting the adaptive nature of the problem and setting more realistic timeframes. I think there are things, and I think that there are wonderful examples of commissioners working alongside trusts to really help them with the analytic problems and the technical capability to make sense of the data. I think what I hear from the patient experience managers is that they don't meet commissioners very much. So where's the connection between commissioners and the people who are charged with patient experience in trusts. That connection would really pay dividends, I think. I think, again, there's something about reducing the number of priorities that you expect organisations to act on in any one time, and also collaborating with other commissioners who work with the same providers in order to reduce the number of priorities that organisations are expected to handle. And then the last thing is very much for commissioners, and it's very much something at this moment in the financial year, which is to avoid as much as possible urgent requests for new work to use up underspends that completely throw everybody off for 2 or 3 months, chasing hares that aren't going to deliver anything very useful. So I think that we should not expect the waves to go away. They are going to continue to roll in. But I would hope that if we were more serious about recognising that these are adaptive problems and that what we need are services that are capable of adapting to new challenges, that they would begin to quieten and we would pay more attention, be able to pay more attention to the support that staff need on the ground to change the way that they work with each other and with patients. And with that, I will say thank you, and we'll move to the next bit of the morning.